Hi there, my name is Rose Schmidt, and I'm a PhD candidate at the University of Toronto. Unfortunately, I tested positive for COVID this morning, so I was unable to present at Lisbon Addiction, but I thought I would record and upload my presentation in case anyone was interested in seeing it. The title of my presentation is, I Don't Chase Drugs Anymore and I'm Not Dead. The Impact of Safer Opioid Supply Programs in Ontario, Canada on Clients' Health and Drug Use. I'd like to start by acknowledging the project team, including the project's Community Advisory Board, the project's funder, which is the Ontario HIV Treatment Network. I need to say that my doctoral work is funded by SSHRC, and I have a Knott Fellowship for Public Impact, but I don't have any other interests to declare. The work was also conducted in Toronto, Canada, which is the traditional territories of the Anishinaabe, the Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. In Canada, there continues to be an ongoing death crisis that's driven by the volatility of unregulated drugs that are contaminated with fentanyl, fentanyl analogs, and increasingly benzodiazepines. Although treatments like methadone do reduce the risk of overdose death and improve health outcomes, more than half of patients who start methadone drop out within a year. Recently, Health Canada has funded a few opioid safer supply programs, or SOSs, that prescribe off-label pharmaceutical-grade opioids as an alternative to the toxic unregulated supply that's in Canada. This presentation is based on an evaluation of 5 SOS programs in Ontario. Between February and October 2021, we examined the implementation and adaptation of these programs, it's 4 programs, but they're across 5 sites. One of these is in London, Ontario, and 4 are in Toronto. Health Canada funded the 4 pilot programs starting in 2020, and it was a part of a response to COVID-19, although one of the programs was operating, the program in London, prior to this funding. In our evaluation, we used a mixed method design, including semi-structured interviews with clients, service providers, and pharmacists, coupled with sociodemic and drug use surveys. The presentation today is based on a thematic analysis of the client interviews. That's London, and that is Toronto. These programs all used a primary care model and served marginalized communities within community health centers. The programs were developed to be delivered by family doctors and nurse practitioners that don't have specific addiction specialties. All of the programs prescribe high-dose tablet hydromorphone or Dilaudids, mostly for take-home dosing. And most of the clients, but not all, were also prescribed some sort of longer-acting opioid as sort of a backbone to treatment, such as slow-release oral morphine, Cadian, or buprenorphine, or more sort of traditional OAT. These were dispensed and administered as daily witnessed, but at a pharmacy of the client's choice. So this presentation describes the results of interviews with 52 clients. The mean age of the clients in our study was 47 years old. Just over half, 56%, was male. Everyone identified as cisgender. 14% were HIV positive, and 17% were self-identified as Indigenous. So this slide shows a little theory I'm starting to develop on sort of what leads to the outcomes of the intervention. And I think I want to draw your attention to the big gray box, which I think is really important, and that's the client's alive. Due to reduced use of contaminated illicit supply, the client's alive. And that's a precursor for sort of all of the other outcomes, which include things like increased healthcare utilization, reduced criminal activity, which led to improved health, increased stability, and improved social determinants of health. I'm going to go through each one of the major themes now in a bit more detail. One of the most striking and frequently reported outcomes was that due to their involvement in the program, clients had not experienced a fatal overdose, and therefore they were still alive. Over half of the clients made a statement like, "It saved my life. It saved countless friends' lives. I don't think I'd still be alive without the program. I'm alive. It's a pretty big impact." Clients attributed their reduced risk of overdose to having a supply of opioids of known potency, quality, and dose. Every client we interviewed also said because of the program, they'd either completely stopped using fentanyl or they had reduced their fentanyl use. Reduced drug use was reported more frequently, though, than completely stopping using street-based drugs. Many clients described how they were better able to manage their withdrawal symptoms now that they had a steady access to prescription opioid medication, and how this was helpful in reducing or coming off of street-based fentanyl. In the context of reduced opioid use, as well as among people who didn't really reduce their use, there was examples of how the program changed how they use their drugs. So, for example, decreasing the frequency of injection. Although the clients are dispensed hydromorphone as a tablet, many, at least initially, do crush these pills and prepare them for intravenous injection. However, over time, several participants describe how they transition from taking their safe supply intravenously to orally. Oh, I swallow now. I swallow. If I wanted to poke, I'll poke, right? But I don't have to. Before the program, most clients were stuck in a difficult and persistent cycle of criminal activity and opioid use. They had to participate in illegal activities in order to obtain money, to buy unregulated opioids in order to avoid withdrawal symptoms. These clients provided clear examples that contrasted their experiences of being criminalized as a person who used drugs compared to being in a program where they could access regulated medications. All of the clients who'd been to jail said that now having a prescription had kept them from going back to jail, and some of them had presented this as a cost savings argument related to the justice system. Several clients discussed how having to do crimes had affected their self-image. A renewed sense of self was a recurring theme among clients, particularly those who saw their past crimes as character flaws, violent acts against innocent people, or as unethical. Prior to their enrollment in the SOS programs, most clients had been disconnected from the healthcare system. Clients described feeling being heard and believed by service providers in these programs, and that that had been a pathway where they could rebuild trust in the healthcare system. Many clients spoke about better pain management, and as a result, having better sleep, more energy, and the ability to engage in activities of daily living. As a result of both reduced injection practices and increased access to healthcare, clients reported fewer abscesses and improved endocarditis. This was also associated with fewer visits to the ER. Some clients were now taking other medications on a regular basis for managing chronic conditions like diabetes and HIV, and they described how these medications were easier to adhere to because of the increased stability in their lives, but also because they were dispensed at the pharmacy at the same time as at their Safer Opioid Supply medication. The increased connection to healthcare services also contributed to many clients attending to health problems that they had previously had been unattended to, like diagnostic procedures and eye and dental care. Clients described increased stability in their lives, including increased income, improved housing and food security, improved relationship with friends and family, and decreased criminal activity. Most clients spoke about the SOS's impact on their finances or income and attributed these changes to no longer having to buy unregulated opioids. Clients felt accomplished when they described having money in their pockets and spoke about how they were now able to spend money on things other than opioids. Stability also meant having a steady routine and meeting responsibilities. So, for example, several clients noted they were now able to pay monthly bills or were able to budget. About half of the clients had re-entered the workforce or school or were volunteering. As a result of going back to work and being able to save money, some clients described that they were able to get out of homelessness and now had an apartment. And a few clients said they were able to move away from drug-using peers, which further increased their stability. For example, one client described how they were able to find housing that had been suitable for them to now have visitation rights with his daughter. Many clients described how being on the program had changed or renewed their sense of self. Clients described experiencing stigma and shame associated with drug use and criminalization, and they felt like they had been disowned by society while they were using unregulated drugs. However, because of the program and the increased stability in their lives, many clients now really saw themselves differently. Being able to feel more normal was a significant part of many clients' renewed self-identity and how they identified success of them for the program. The clients spoke about the shame that they had felt about prioritizing drug use over taking care of their health and relationships and doing things that they hadn't been proud of, like stealing and lying because of their substance use. But they no longer had to engage in these activities. Most clients spoke about being able to participate in their life more actively, and how participating in doing things like paying bills, re-engaging with family members was a source of pride. So our results indicate a multifaceted pathway that resulted in improved self-reported health outcomes among clients. These included reduced injecting behavior, decreased cravings for illicit opioids, which had less criminal activity, coupled with increased stability, improved trust in healthcare, better mental health, and renewed self-identity. Importantly, most clients reported the intervention saved their life because it reduced the frequency of overdoses, which provided them an opportunity to make other changes in their life. Our results have several implications. A multifaceted approach is needed to address the overdose death crisis, and SOS programs are one facet of this response. While there has been some concern raised about these programs, particularly from some members of the addiction medicine community, our study does add to the growing evidence that supports them. Of course, studies are needed at the population level to look at overall overdose rates, as well as accounting for the potential of diversion, as well as longitudinal studies that look at the impact at the individual level. Our results could provide the basis for developing quantitative indicators that can continue to produce this evidence as on the impacts as well as the mechanisms of these programs. Our results also have several implications for services for people who use drugs. The delivery of the programs that I've described within the wraparound support of a community health center really helped make clients feel heard and cared for well beyond their safe supply prescription. Many people who use drugs aren't interested in engaging with treatment due to negative past experiences and a desire to have more control over their drug use. SOS programs differ from OAT like methadone, which are characterized by oral admission, no euphoria, and sometimes but not always observed consumption. Providing clients with what they wanted, a tablet that could be injected and did provide euphoria for at-home dosing, helped establish trust with service providers and helped re-engagement with healthcare. There is a need for non-medicalized alternatives. This is just one way of delivering SOS or safe supply. And things such as compassion clubs and the decriminalization and legalization of drugs is also needed. These measures will further reduce opioid overdose risk, as not all people who are at risk or do die of a toxic drug poisoning meet the criteria for opioid use disorder or the criteria for enrollment in a program such as this. The closest thing I could describe it to would be playing the lottery. You're not going to have to worry about your bills. It's that reassured feeling. That's the feeling. That's the closest thing I could describe it to. Thank you very much. And if you have any questions, please feel free to email me or follow me on Twitter. Thank you.